Hello, my name is Sharita Wilson. Today, as a nursing student, I'm going to walk you through the challenging process of performing coronary artery bypass surgery. I'm going to begin with a set of 24 PowerPoint slides and introduce you to the meaning of coronary artery bypass surgery. It is a procedure used to treat coronary artery disease and the narrowing of coronary arteries, in which the blood vessels that supply oxygen and nutrients to the heart muscle. To treat the locked or narrowed arteries, you must bypass the blocked portion of a coronary artery with a piece of a healthy blood vessel from the body. The blood vessels or grafts used for the surgery process may be pieces of a vein from your leg or an artery in your chest or wrist. The symptoms include chest pain, fatigue, palpitations, abnormal heart rhythms, shortness of breath, swelling in the hands and feet, and indigestion. There may not be any symptoms in early stages of coronary artery disease. The disease can progress without warning. If the blood supply to the heart muscle decreases as a result of increasing blockage of a coronary artery, then it will result in cardiac arrest. If the blood flow can't be restored in a particular area of the heart muscle, then the tissue dies. If there are other reasons for coronary bypass surgery, then your doctor will recommend coronary artery bypass surgery. The risks include bleeding during or after surgery, blood clots that could cause a heart attack, stroke, or lung problems, infection at the incision site, pneumonia, breathing problems, pancreatitis, kidney failure, abnormal heart rhythms, failure of the graft, and death. There are many other risks depending on an individual's medical condition. Therefore, it is important to discuss these concerns with your doctor before agreeing to this procedure. The preparation process includes the doctor explaining the procedure, asking his or her patient's questions, asking to sign a consent form that gives the patient the doctor permission to perform the operation. The patient must read the form carefully, ask questions if anything is unclear, and a doctor may ask for a review of health history. Your doctor will do a complete physical exam to make sure you are in good health. You may need blood tests or other diagnosis tests. You will be asked not to eat or drink for 8 hours before the procedure begins, especially after midnight. You will have to bathe with soap or a special cleanser the night before and the morning of a surgery. Tell your doctor if you are pregnant. Tell your doctor if you are sensitive or allergic to any medicines, iodine, latex, tape, or anesthetic medicines, whether local or general. Tell your doctor about all medicines and supplements you are consuming. Tell your doctor your history of bleeding disorders or if you are consuming blood-thinning medicines that affect blood clotting. You will be told to stop taking these medications before the procedure. Your doctor may do blood tests before the procedure to find out how long it takes your blood to clot. Tell your doctor if you have a pacemaker or any other implanted cardiac device. If you are a smoker, quit smoking as soon as possible. This will improve chances of a successful recovery from surgery and benefit your health. Based on your medical condition, your doctor may ask to do other things to prepare for the surgery process. The process includes removal of jewelry or other objects, changing into a gown, emptying bladder, lying on your back on the operation table. The anesthesiologist will continuously monitor your heart rate, blood pressure, breathing, and blood oxygen level during the surgery. Once you are sedated or put to sleep with a medication, a breathing tube will be placed into your throat and you will be connected to a ventilator, which will breathe for you during the surgery. A healthcare professional will insert an intravenous IV line into your arm or hand. A catheter will be put into your bladder to drain urine. The skin over the surgical site will be cleansed with an antiseptic solution. The doctor will make an incision or cut below the Adam's apple to just above the navel. The doctor will cut the sternum or breastbone in half. He or she will separate the halves of the breastbone and spread them apart to expose your heart. Coronary artery bypass graft surgery, the pump procedure. To sew the grafts onto the very small coronary arteries, your doctor will need to stop your heart for temporarily. Tubes will be placed into your heart so that your blood can be pumped through your body by a heart-lung bypass machine. Once the blood has been diverted into the bypass machine for pumping, the doctor will stop the heart by injecting it with a cold solution. When the heart stops, the doctor will do a bypass graft procedure. The doctor will sew on the end of a section of a vein over a tiny opening in the aorta, the other end over a tiny opening made in the coronary artery just below the blockage. If your doctor uses the internal mammary artery inside your chest as a bypass graft, the lower end of the artery will be cut from the inside of the chest and sewn over an opening made in the coronary artery below the blockage. Depending on how many blockages you have and where they are located, you may need more than one bypass graft completed. After all the grafts have been completed, the doctor will closely check them as blood runs through them to make sure they are working. The doctor will let the blood circulating through a bypass machine back into your heart, and he or she will remove the tubes. Your heart may restart on its own, or a mild electric shock may be used to restart it. Your doctor may put temporary wires for pacing into your heart. These wires can be attached to a pacemaker, and your heart can be paced if needed during the initial recovery period. Cabs on pump procedure. Once your doctor has opened the chest, he or she will stabilize the area around the artery to be bypassed with a special instrument. The rest of the heart will continue to function and pump blood through the body. The heart-lung bypass machine and the person who runs it may be kept on standby just in case the procedure needs to be completed on a bypass. The doctor will do the bypass graft procedure by sewing one end of a section of a vein over a tiny opening made in the aorta. Cabs off pump procedure. The other end over a tiny opening made in the coronary artery just below the blockage. You may have more than one bypass graft done, depending on how many blockages you have and where they are located. Before the chest is closed, the doctor will closely examine the grafts to make sure they are working. The procedure completion of both methods includes your doctor will sew the sternum together with small wires like those sometimes used to repair a broken bone. He or she will insert tubes into your chest to drain blood and other fluids from around the heart. Your doctor will sew the skin over the sternum back together. Your doctor will put a tube through your mouth or nose into the stomach to drain stomach fluids. He or she will then apply a sterile bandage or dressing. After the process of coronary artery bypass surgery in the hospital, you will be taken to the intensive care unit to be closely monitored. Machines will constantly display your electrocardiogram tracing, blood pressure, other pressure readings, breathing rate, and your oxygen level. CABS requires an in-hospital stay of at least several days. You will most likely have a tube in your throat to help with breathing through a ventilator until you are stable enough to breathe on your own. As you continue to wake up from the anesthesia and start to breathe on your own, your doctor can adjust the breathing machine to allow you to take more of the breathing. Once you are awake and can breathe on your own, your doctor will remove the breathing tube. After the breathing tube is out, a nurse will help you cough and take deep breaths every couple of hours. This will be uncomfortable due to the soreness. Therefore, you have to keep coughing to keep mucus from collecting in your lungs and causing pneumonia. Your nurse will show you how to hug a pillow tightly against your chest while coughing to help ease the discomfort. The surgical incision may be tender or sore for several days after procedure. Take a pain reliever for soreness recommended by your doctor. Aspirin or certain other pain medications may increase the chance of bleeding. Therefore, you must make sure to take recommended medications recommended by your doctor. Your doctor may deliver medicines through the IV to help your blood pressure and your heart and control problems with bleeding. As condition stabilizes, he or she will decrease and then stop these medicines. Once your doctor removes the breathing and stomach tubes and you are stable, you may start to drink liquids and include more solid foods. When your doctor determines that you are ready, you will be moved from the ICU to a post-surgical unit. The recovery will continue. You can increase your normal activity by getting out of bed and walking around for longer periods of time. A member on your care team will arrange for you to go home and schedule a follow-up visit with your doctor. The at-home process. Keep surgical area clean and dry. Your doctor will provide bathing instructions. Your doctor will move the sutures and surgical staples during a follow-up office visit. Do not drive until your doctor recommends it's okay to do so. Let your doctor know the following. If you have a fever of 100.4 degrees or 38 degrees Celsius or higher or chills, redness, swelling, or bleeding, or other drainage from any of the incision sites, increase in pain around any of the incision sites, trouble breathing, rapid or irregular pulse, swelling in the legs, numbness in the arms and legs, and last but not least, persistent nausea or vomiting. There's a demonstration video I would like to show of doctors performing the coronary artery bypass surgery.
The mammary artery has been used in coronary vascularization for years, starting in the 50s as part of the Vanberg procedure, in which the mammary artery was implanted directly to the myocardium. The technique of direct coronary anastomosis with the aid of magnifying loops was perfected at the Cleveland Clinic by Tavaloro and his associates. And in this paper by Loop and Associates from the Cleveland Clinic, published in the New England Journal of Medicine in 1986, the superiority of a mammary artery compared to saphenous vein grafts was demonstrated both in terms of graft patency and clinical outcomes, and established the mammary to LAD as the quintessential component of a CABG. The logical question was then whether a single internal mammary artery versus a bilateral internal mammary artery vascularization was a superior strategy, and again the group at the Cleveland Clinic demonstrated that the survival curves begin to diverge after 5 years in favor of a bilateral internal mammary artery revascularization strategy. Importantly, the survival curves begin to diverge at 5 years and continue to diverge in favor of Lima with time. Because the Cleveland Clinic study and other observational studies demonstrated that the benefit of bilateral mammary manifests after 5 years, it is not surprising that the interim analysis of the ARC trial showed negative results at 5 years. The primary endpoint is at 10 years, and those curves may well diverge with time. In addition, we think that the incremental benefit of adding an additional mammary bypass to the Lima to LAD would depend on the size and importance of that additional vessel bypassed with the second mammary. Despite the potential benefits of a bilateral internal mammary artery vascularization, only 4% of CABGs performed in the US utilize the bilateral internal mammary artery technique. There are concerns about increased risks of mediastinitis and sternal wound complications, but those could be mitigated with skeletonization and meticulous harvesting techniques. In this video, we start by showing the harvesting of the right internal mammary artery. The left internal mammary artery has already been harvested. We utilize the non-touch technique with minimal manipulation of the conduit itself. We grab the periadventitial tissue and fat and use the forceps to push the conduit away from the surrounding tissues. Branches are controlled with the use of electrocautery or application of hemoclips, as demonstrated here. The field has to be bloodless. The use of a piece of gauze supply traction is also a useful atraumatic technique in harvesting skeletonized mammaries, or for that matter, pedicle mammaries. If you get into bleeding, take time to carefully identify the branch source, control it, and apply a clip, as demonstrated here. The electric artery is usually set at 20 or 30 to minimize the risk of thermal injury to the conduit. Our aim is to harvest a mammary that has minimal hematomas and looks white and suffers no spasm. Here one of the terminal branches of the right internal mammary artery is being clipped and cut. And notice that a nice, lengthy, skeletonized mammary ends with supplying the right diaphragm. Next, we move proximally to mobilize the mammary. We use the fingers of the left hand to retract on the mammary and push away the lungs. In addition, we ask for anesthesia's help to use low tidal volumes or hold ventilation as necessary to achieve our objective. Now we're cannulated and the left internal mammary artery is being prepared, is distal and dispatulated with a fine scissor. The right internal mammary artery is then clipped distally and divided in a similar fashion as we did for the left internal mammary artery.
Ew.
With the heart still off the heart lung machine and the heart distended and beating, this would be a good time to assess the length of the right internal mammary artery and see whether it would be a better fit for a right target or a left target through the transverse coronary sinus. The transverse coronary sinus is demonstrated in this diagram. It runs behind the aorta and the PA, and the mammary would run from the right side over the superior vena cava and behind the aorta and the pulmonary trunk on top of the roof of the left atrium. Here you would see the right hand palpating and feeling the space through which the right internal mammary artery conduit will transverse. We create a slit in the pericardium to allow the right internal mammary conduit a gentle lie through the transverse sinus. Care is taken to avoid injury to the right phrenic nerve. We go on cardiopulmonary bypass and apply aortic cross clamp and give cold blood potassium cardioplegia in an antegrade and retrograde manner throughout the case to achieve an excellent diastolic rest of the heart. Topical cooling is used as an adjunct as well. The target vessels are then explored. Again, in this case, it was felt that the best target will be a left-sided target, a high OM, and the cavalloro is used here to pass the right internal mammary artery through the transverse sinus and retrieve it on the left side of the heart as demonstrated here. Next, a coronary arteriotomy is performed. The CO2 blower is the usual adjunct to enhance the visualization of the target vessel. An appropriate match is created between the size of the arteriotomy and the spatulated mammary conduit. A helpful technique here is to have an assistant pull the mammary upwards as demonstrated, and then to blow down into the lumen of the mammary. Enhances visualization of the lumen and allows the surgeon to take full thickness bites of the mammary at the heel, reducing the risk of backwalling it and enhancing the precision of the anastomosis. The distal anastomosis is constructed using the standard fashion of running number 7 Oponi suture as demonstrated here. Small and precise bites are taken full thickness of the mammary artery, and a matching bite is taken of the coronary target, incorporating some of the epicardium so as to enhance the hemostasis of the anastomosis, but avoiding excessive bites that would result in compromise of the lumen at anastomosis. We de-air the anastomosis just before tying the proline, and as soon as the anastomosis is complete, we check flow through the mammary. Still on cardiopulmonary bypass, we feel that this is a useful adjunct to indicate the integrity of the anastomosis and allow us to proceed to the next step. This check is repeated after coming off cardiopulmonary bypass. The LAD is being palpated to identify a soft spot to construct the Lima to LAD anastomosis. The LAD arteriotomy is performed, and the size of the arteriotomy is matched to the Lima, as has previously been demonstrated for the anastomosis of the Lima to the lateral wall target. Here, an eyeball retractor applied to the epicardial fat enhances exposure. We create a tunnel through the pericardium for the left internal mammary artery. Despite being on pump, it's still important to estimate a good lie for the mammary, ensuring that there's no kinking and predicting the adequate length that is needed to construct a suitably configured anastomosis. As you can see, the mammary is being trimmed, and the distal end is prepared for the anastomosis. The assistant upwards, and CO2 is being blown through the lumen, enhancing exposure and allowing accurate and precise bites to be taken of the mammary. The anastomosis is then constructed in a routine fashion, again taking small bites of the target vessel but incorporating some epicardium to enhance with the hemostasis. We find that oftentimes it's helpful to retain some redundancy of the mammary to allow the system to grab and enhance exposure, but then we trim that as we tailor the perfect match between the mammary spatulated end and the target vessel arteriole. The bites at the outflow of the LED are obviously the most important and should be taken with great precision. This anastomosis is obviously the most important anastomosis within this operation. One possible technical caveat is accidentally implicating excessive mammary tissue into the lumen of the anastomosis. This can result in narrowing of the anastomosis and compromise of the flow. Excessive mammary tissue should be ideally trimmed, or if there's a small amount of excess, it can be excluded by externalizing it through a fork outside the lumen of the anastomosis instead of imbricating it into the anastomosis, thus avoiding any narrowing of the lumen. As you can see, the bulldog is released to clear the anastomosis, and then sutures are tied, completing the limat LED anastomosis. We use the TEE routinely to check for cardiac function and to ensure adequacy of the gearing procedure. Bilateral mammary artery revascularization can be performed with different configurations. We prefer the configuration on the left side, in which there are two in situ mammary arteries with two separate inflows supplying the bypassed heart. So there is additional security in having two sources of blood supply, and also the gold standard limat LED is uncompromised by any additional anastomosis or manipulation. The right internal mammary artery is usually bypassed to a left-sided target, such as a diagonal, a ramus, or a high OM, ideally with high-grade stenosis, and also the more important and the larger that vessel is, the higher the incremental benefit of utilizing an additional mammary for coronary artery bypass grafting. Sometimes we bypass the right internal mammary artery to the highly stenosed right coronary vessel or to the proximal part of its distal branches. The right-sided picture demonstrates a composite configuration technique in which multiple arterial segments are taken off the left internal mammary artery. This technique may be useful in certain scenarios where the conduit length may be problematic and allows for a wider reach for the arterial anastomosis across the surface of the heart. Before we conclude, I'd like to bring to your attention the Society of Thoracic Surgeons Clinical Practice Guidelines on arterial conduits for coronary artery bypass grafting. The guidelines state that mammary arteries should be used to bypass the LAD, and as an adjunct to the mammary to the LAD, A second arterial graft, such as the right internal mammary artery or radial artery, should be considered in appropriately selected patients, and that the bilateral internal mammary artery should be considered in patients who do not have an excessive risk of sternal complications. To summarize, key principles guide our bilateral internal mammary artery revascularization strategy. First, patient selection. We believe that many patients would benefit from a bilateral internal mammary artery revascularization, but certainly not all patients qualify. Second, the REMA target should ideally have a high-grade stenosis and should be an important vessel. And what we mean by important vessel is that it reaches the apex of the heart or almost to the apex of the heart.